Ready?
Yep.
Okay, I'd just like to welcome everyone to day 2 of International Nurses Day. So we've got a fun-packed hour and a bit for you today. We're talking about everything to do with advanced care nurse practitioners, which I'm really excited about. So we'll just go through a little bit of etiquette. So microphones on mute throughout so everyone can hear the speakers clearly. Use your hands up option if you want to say something, and then I'll ask you in for whatever you need to say. There'll be a questions section at the end of each presentation, but if for any reason we don't have time, there is a Q&A session right at the end of all of the presentations today where you can ask the panel any questions you want. So I will keep an eye on in the chat and try and make a note of any questions that come up in the chat sort of as you think of them. And if your connection isn't great, we may ask you to turn off your cameras. Okay. So this is the programme for the week. So as you can see, today is all about advanced nursing practitioners. So we've got genomics in nursing, which is advanced nursing as well in the middle of that. Tomorrow, it's a celebration of specialist nurses. So that looks really interesting as well. How's your bum? That looks like a very interesting session to attend. Day 4, we've got Professor Catherine Mason, who some of you may know is the coroner for Leicester City, coming and doing a talk. So that will be really interesting. And day 5 is all about quality, celebrating nursing past and present future, and about quality as well. So it's a really good week, and I hope as many of you can join as many sessions. So today we're going to start off with Angela Richardson, who's from CHS, who's going to give us a talk about the advanced nursing practice framework. Over to you, Angela.
Thank you, Jackie. So Dan and I are going to do a bit of a double act for the next sort of 10-15 minutes, and I'm going to start, as Jackie says, by just giving a bit of an overview of the strategic framework for the development and management of advanced clinical practitioner roles. I think, first of all, it's just important to say a little bit about advanced practice, in that advanced practice isn't a qualification, but it is a level of practice. So because of that, it isn't regulated. So therefore, there can be lots of levels at which you are functioning and call yourself an advanced practitioner. So clearly that has implications for patients and the public, because they have a right to expect with a title that if you are calling yourself something, then there is an expected level of practice. And so for many, many years now, there's been lots of debate within predominantly nursing, but this is not about nursing, this is about all professions, as to how advanced practice should develop, and how there should be some, not regulation, but some framework or some guidance as to what should be expected at that level. The framework, the LLR framework, is a large document, and I have sent it to Anita, so if anybody wants a copy and wants to look at it, wants to read it, please feel free to ask for that, because this is very much a whistle-stop tour. Could you move the slide on, please? Thank you. So our framework is based on the Health Education England framework, which came out in 2017. There was lots of guidance since, but this was really the first piece of real sort of robust guidance for the development of advanced practice. And as it says there, it's a framework for assessment, ongoing professional development, and most importantly, stringent governance structures to make sure patients have high quality, safe and effective care. And our framework is based on this Health Education England framework. I don't want to say next slide, please, because that's so Chris Whitty, isn't it? But I have to say that because it's lovely. It's really nice, and you have a feeling of power. Thank you. So just a little bit about advanced clinical practice. So it's delivered by experienced registered healthcare practitioners. And for me, in that sentence, the key is it's characterised by a high degree of autonomy. So it's autonomy that's very much a feature of advanced practice. And what goes along with that is complex decision making. Now, this is underpinned by a master's level award, but again, it's important to say or equivalent. So as I've said, advanced practice is a level of practice, it's not a qualification. And so there are lots of things that you know can contribute towards advanced practice, clearly experience being a huge one, and lots of different sorts of training and study. So it doesn't have to be advanced practice, a master's level award, but there will need to be, and this is what is being developed by Health Education England, some process for demonstrating that you can practice at that level and give assurance that you are practicing at that level. Advanced practice requires practitioners to demonstrate core capabilities and area-specific clinical competence within 4 distinct pillars. And if we move the next slide on, they are the 4 pillars of advanced practice. And if there's anything you want to remember about advanced practice that anybody ever asks you about, remember the 4 pillars, because they're the things that underpin the level of practice. So clearly clinical practice, leadership and management, education and research. And that can be, you don't have to be a researcher to practice at advanced practice, but all of these 4 things have to be part of your practice. Thank you. God, I didn't even say anything then, it moved automatically. Thank you very much. So the key features of the framework. So as I've alluded to, it discusses the core principles of what advanced clinical practice is and what the role requirements are within LLR. It covers selection and recruitment. It covers what the academic and training programme is, because within our organisation, we don't just employ people at advanced practice level, we have programmes that train them to be able to function at that level. It covers supervision and support, which is really important because that is usually multi-professional. So to work at advanced practice level, there's often, we're crossing boundaries, professional boundaries, and there's often different elements of requirements of supervision and support. Governance, which is probably the one that I should have put at the top, is really important. As I said, that is not regulated. Advanced practice isn't regulated. Therefore, it's important to have really robust governance structures to ensure that the care you're providing is safe and effective. The framework covers workforce planning and sustainability, research and audit and how that applies to LLR advanced practice roles, transition through ACP banding, because again, there's been lots of national debate about banding and where you should be banded. There are lots of different bandings for ACPs, but again, the framework gives a clear outline for how we're following that within the LLR. And it also covers new skill attainment. I'm going to now hand over to Dan, because I think in what he's going to say, that probably then shows how the framework has been applied to the service that we have in CHS. Dan, it's all yours.
Thank you very much. I'll try and now share my screen because I wasn't quite organised enough to get my slides in.
So you can't say next slide, please, now, can you?
There you go. Can everybody see that?
Yes, I can.
Lovely.
Yep.
So I'm just going to talk to you about our community hospitals and actually the role of the advanced nurse practitioners that we have. So our service model around our community hospitals, each community hospital or community ward gets 2 sessions per week from a consultant geriatrician, but overseen by our consultant nurse, Angela, who's just spoken to you. Each ward at the moment has a master's educated advanced nurse practitioner. We work 9 till 5. Most of us tend to work 8:30 till about 5:30 and 5 days a week. At the moment, we're unable to have a lot of ACPs due to ongoing prescribing limitations for non-nurses, such as physiotherapists can prescribe fentanyl, but they can't prescribe codeine and morphine. Outside of these hours, we're covered by the DHU home visiting service, and we also have a number of trainee AMP positions as well. So what type of patients do you see in our community hospitals? So we basically see everybody over the age of 16. We aim to have everybody over the age of 65, but in my 9 years of working here, I've looked after pregnant women, prisoners, homeless people. We have a lot of our larger population that are coming through now needing specialist equipment. We look after surgical, medical, frail, homeless, end of life, repatriations back to Leicestershire, you name it, and we've probably had it on one of our wards. It just goes to show we have a nice array of patients. So what are our AMPs doing in the community hospital? So each advanced nurse practitioner is trained in performing a comprehensive geriatric assessment. We order, interpret blood results. We order and action X-rays and scans and ECGs. We try and work very closely with our colleagues at UHL to streamline patients. So just because they're in a community hospital doesn't mean that they're not entitled to the same level of care that they deliver. We use stop-start methods, so we're used to stopping quite a lot of medications. We have management of long-term antibiotics, such as your osteomyelitis patients. We work very closely with the MDT and liaise with families about the medical management of their relatives. We support the consultants on their ward rounds because a lot of them have seen maybe 30 patients in the morning, so they need a little bit of guidance to remember who's who on their wards when they come out here. We also support staff with development and also education. That ranges from your HCAs to your nurses, to your physios, to your OTs. And we also help train the future of the AMPs, but also we have a lot of medical students that spend time with us and also PA students. So what medical treatments happen? So we provide continued support for those patients already on NIV and CPAP and low-grade oxygen therapy delivery. We give blood transfusions, we have incontinence management, IV antibiotics, furosemide for heart failure, IV fluids. We start anticoagulation because a number of our patients come to us with new onset AF, and we're also a go-to guys for the palliative care team in the community when they need a bit of help with their end-of-life care. So what have we gained? Well, definitely, as Angela said, we have a lot of autonomy. Certainly, some of the new AMPs coming through are struggling with the amount of autonomy that they have, especially the ones that come from UHL. They're used to working in quite a medically led team, and this is very much a nurse-led team. We have a number of publications. So personally, I've published along with Professor Ghosh about our COVID patients that we had out at Hinckley. We have someone that sits on quite a high up in the research committee. We're doing numerous presentations. So we've presented our model down in London on one of their advancing practitioner days. And we've got a well-respected and envied service throughout the UK. And that is pretty much our service. Oh, now, does that stop sharing now?
It has.
It has, yeah.
Brilliant. So that's a bit of a whistle-stop tour of what we do in our community hospitals. Probably an eye-opener for many, or a lot of you already know what a great service we've provided.
Lovely. Thank you very much, Angela and Daniel. Sorry, Daniel, I didn't introduce you at the beginning because I thought you were doing it on a separate section. So sorry, my error. Has anybody got any questions for Angela or Daniel? Claire?
Thanks, Jackie. This is really timely for me because I'm meeting this afternoon with a nurse who's at an early stage of her career and she's very interested in pursuing advanced practice. And I just wondered, Dan and Angela, whether you got any words of wisdom I could share with her, any advice?
I mean, for me, I got into advanced practice because I was ready to make that next step. I didn't want to go and do my 5 years of medical school training as you need to do now, but actually I wanted some autonomy. So that's why I took this avenue.
Yeah, and I think I would agree with that, Dan. I think it's about, I know we keep using the word autonomy, but it's also about responsibility, isn't it? And it's when you get to that, whether it be it's via experience and study, isn't it? And you get to that point where you feel that you're able to move forward. And we all move forward in different, I think with a lot of advanced practice, it is quite clinically focused and based around, and it's for those people who want to develop in that way. Some people like to have more of a and it's not that in advanced practice you don't have a strategic view, but it's about where the focus of your practice is, I think, and it's for those people that want to do that rather than move away and maybe more operational or more strategic in their development.
It definitely helps me because throughout my career, it's very clear that I'm not a managerial person. I'm more of a clinical based person.
Thank you. It's really exciting that there are these options now for nurses, which there really weren't when I qualified. So I know Angela's very aware we're a long way behind CHS, but within the mental health services, we are now building up a cohort of advanced practitioners who are really keen to link in with all of you. So yeah, it's just really exciting to seeing it take off across all the different specialties in the trust, isn't it?
Just take one question from Emma.
Thank you. I was going to ask that question, Claire, because I think it's always good to ask, what advice would you have for your younger self or somebody embarking? So I'm going to ask a question just in terms of being a nurse in an advanced role. How do you maintain that link to the profession? And because I think you've talked about different medical models and influences, and I think when you do advance clinically, skills wise, it'd be really nice to hear about, because we're celebrating nursing, how you maintain that connection, so to speak.
Well, from my point of view, I was so far along in my career that actually nursing was part of my soul. It was ingrained, and I can't change that no matter how much I try to be part of a medical model. It's very difficult balancing the two, because when I'm on the ward and I'm looking after the patients and I see that the nurses are struggling or there's staffing problems, it's very difficult to not put my old nursing hat on and help, because I've got my own job to do. But I think that one of the benefits of being an advanced nurse practitioner, especially in our elderly, frail group that we have, and no disrespect to my medical colleagues, but with your nursing hat on, your communication skills are a lot more enhanced. And actually, they feel a lot more at ease being in a community hospital than they do at the Leicester Royal or the Leicester General or any acute trust.
I would agree with that, Dan, and I think it's about your head and your heart, isn't it? I mean, I often don't describe myself as a nurse anymore, and that has been a bit. I've done that in forums where it's been quite controversial, and people, because I don't see myself as a nurse in my head, and I probably think differently. However, my heart, as you say, it's ingrained in you because you did it for so long. So, we're advanced practitioners with a nursing background, aren't we? But that nursing background never leaves you. It never does, because of all those skills that you gain that you've taken to advanced practice. And that was why you probably became a nurse in the first place, wasn't it? Because they were the skills you wanted to develop.
Lovely. Thank you very much. I'd just like to move on to the next speaker now. I'd like to introduce Vicky Noble, who is an advanced clinical practitioner and is leading the way in the Directorate of Mental Health for responsible clinicians. So, Anita, if you could put a presentation up, that would be great. Thank you. Over to you, Vicky.
Sorry, I apologise. Right, I'll start again. So my name's Vicky Noble. I'm one of the advanced clinical practitioners within the Directorate of Mental Health, and I'm also a trainee approved clinician. So this presentation is about our journey within mental health. So some of this has already been covered by the previous slide as to the role of the advanced practitioner. So next slide, please. So advanced clinical practice is delivered by experienced registered healthcare professionals. It's a level of practice characterised by a high degree of autonomy and complex decision making. This is underpinned by a master's level award or equivalent that encompasses the 4 pillars of clinical practice, leadership and management, education and research, which demonstrate the core capabilities and area-specific clinical competence. Advanced clinical practice embodies the ability to manage clinical care in partnership with individuals, families and carers, and includes the analysis and synthesis of complex problems across a range of settings, enabling innovative solutions to enhance people's experience and improve outcomes. Next slide, please. So our journey within mental health started about 4 or 5 years ago when 3 of us started our journey at Lincoln University doing our ACP training. Some of us were interrupted by COVID, some of us weren't, but since then the organisation has other clinicians studying for their ACP, and even now having the opportunity for apprentices in ACP doing it full time. All of us are in totally different areas within mental health. I'm currently within the emergency urgent care pathway. So I actually sit over 5 teams, seeing that patient in that acute crisis and often for that first presentation to service. It's a really exciting journey I go with my patients, because often I may be the only person they see from mental health before I am in a position to be able to discharge them back to primary care for long-term management. Next slide, please. What are the benefits for everybody by having ACPs? Research has shown there is a cost-saving element to this, along with reduced length of stay, reduced time to treatment, reduced mortality rates, and improved patient satisfaction. Other research reported improved continuity of care, reduced delays in diagnosis and treatment, along with patient satisfaction and positive effects for junior medical staff and nursing colleagues. For me, it was really important to go on this journey to develop other opportunities for nurses, being a nurse myself, having other opportunities to develop clinically and progress and enhance their skills. Whilst doing this, I discovered the changes to the Mental Health Act. Next slide, please. So in 2007, when the Mental Health Act was changed, it allowed for other disciplines to become trained as multi-professional approved clinicians. This role is partly to ensure that a person who's detained subject to the Mental Health Act is assessed and appropriately treated in conditions that are necessary for the purpose of alleviating or at least preventing deterioration in their mental disorder and any associated risk to themselves or others. This role includes renewal of detention, discharge, approving leave, and making community treatment order applications. The principles which guide decision making around detention being outlined by the Code of Practice. Next slide, please. So this is a very new journey for myself and a colleague who's also started this some months ago. And as of last month, there are a couple of other colleagues joining us on this journey with full-time trainee posts. It's been developed in other areas across the country, and currently there are about 80 multi-professional approved clinicians across the UK. Next slide. So far, it is believed that the benefits are, with there being significant difficulties in recruiting consultant psychiatrists and leaving vacancies across services, the role of the multi-professional approved clinician will be able to take on some of these gaps. There are opportunities for strengthened clinical career pathways leading to lower turnover and better retention of staff, also contributing to lower long-term recruitment costs, making organisational savings. In a recent survey carried out in England and Wales, those working as multi-professional approved clinicians identified that the key benefits for them personally were the enhanced professional roles and support for professional development, where they're able to use their expertise and experience. The implementation of the multi-professional approved clinician role reduces the likelihood of patients waiting to either see a psychiatrist or a locum with who they're unlikely to establish any long-term relationship with. The main driver within organisations is the sustainability of services on a long-term basis, while reducing costs and potentially enhancing overall service quality. The approved clinician roles are expected to deliver improved and positive patient experience and deliver effective care. There will be new models of clinical leadership as a result of increasing the diversity of the approved clinicians, and there'll be a full utilisation of skills of healthcare professionals and improved clinical outcomes, length of stay, and medical optimisation with reduced in polypharmacy. So that's our current journey.
Thank you, Vicky. Has anybody got any questions? Angela?
Thanks, Vicky. That was really interesting. I've sort of read about the AC role, but I suppose, and this may be, I may be a little bit premature, but I suppose, how do you see that? Because it's clearly different to the sort of the ACP role. How do you see the two? It's clearly very advanced. It clearly has autonomy and, you know, high level decision making, but obviously they're significantly different. So how do you see the sort of it fitting within the advanced practice framework sort of thing, or the advanced practice role?
I suppose for me, and again, it's the beginning of my journey as a multi-professional AC, so it's still work, you know, discovering what it will look like. But I suppose, again, it's that critical thinking at a different level and looking at the care and management of that individual patient in a different way to how it's traditionally been done. So using the skills I've gained as an ACP and using it differently.
Thank you. Any other questions? No, I can't see any hands up. Okay, I'll go to the next speaker now, which is Victoria Carr and Annette Breen, who are going to talk to us about genomics in nursing.
Oh, hi everybody. Thanks for asking us to speak. So I'm Annette Breen and I'm one of the lead nurses for the East Genomic Medical Services Alliance. And I'm not sure if you've got our presentation, Anita. So I'm based at Nottingham University Holidays, I was going to say hospital. And my colleague Vicky is based at Cambridge University Hospitals.
Hello, everyone.
Hello. And so I've got a presentation. So going to talk a little bit about where genomics fits in, a little bit about what is a Genomic Medical Services Alliance, the priority work areas for this year, and what we're focusing on, how to get involved, and then training resources. And then just stop me at any points if you've got any questions. So if you'd like to move to the next slide, please, Anita. So genomics, it's very topical at the moment, and there's been quite a lot of things in the news. And what we're moving to is more personalised practice, because I'm sure you've all come across in your routine work, you'll have some patients, they respond really well to medication, others don't, and there don't appear to be, there doesn't seem to be a lot of difference between the two patients, their conditions seem similar. And so one of the things with genomics, and it's quite often used interchangeably with genetics, it's like looking at an individual's gene genetic structure to find out why they might respond to a drug. So with cancer patients, the tumours can be tested to find out, because cancer is a genetic disease, and it's where there's changes in the DNA in the cells in the body, and can do genetic testing on the tumour to find out which chemotherapy might be the most beneficial for the tumour, so targeting treatments. And then at the top of this slide, we've got mention of DYPD gene testing, and that's the sort of testing that's offered to people who are having certain types of chemotherapy for, I think, breast, lung, and other cancers, to find out if they're at risk of a serious side effect, because people who've got a change in this DPYD gene are at risk of toxicity, severe toxicity. And then we've got other sort of testing going on, expansion of non-invasive prenatal testing to give parents informed decision making about their pregnancy. So that might be where they choose to birth their baby and the care for the baby afterwards. So if we move on to the next slide, that's just a little bit of an overview. And so it's very important in the NHS long-term plan. There's been a whole raft of documents published over the last few years about the importance of genomics. I think I can't remember which Minister of Health kicked it off in a few years ago. But I think one of the unique things with the NHS is we have got an end-to-end healthcare service, which is, yes, Jeremy Hunt, how could I forget his name? We have got an end-to-end healthcare service, which is accessible to all members of the population. So we want to be the first national healthcare system to offer the whole genome sequencing as part of routine care. And sort of working on lots of scientific things, sequencing 500,000 whole genomes to help transform care for maximum patient benefit. So lots of scientific stuff going on. But the main thing is to improve the life of people who are affected with a genetic disease, people affected by cancer. And it sort of varies about how their life will be impacted. So for somebody with cancer, it might be optimum treatment. Some cancers have got an inherited genetic component. So it might mean that their follow-up cancer care is different, so that because their recurrence of other cancers would be higher, so they get a longer surveillance period. And then there's children who are sort of seriously ill with genetic disorders. They might be targeting their treatment. And sometimes for families, what is important is having an actual diagnosis for their child who's got multiple developmental problems, so they can sort of link up with other families. Also, we've got sort of familial hypercholesterolemia. there's pathways in place for that, treating families now, which is reducing the number of people suddenly dying in their sort of early to late 40s. And then sort of looking to correlate the data with new treatments and help patients make informed choices about their care. So if we can move on to the next slide, please. So the Genomic Medical Services Alliance, so what are they? So excuse me a moment. So as you can see, there's 7 of them. And why have they come about? So the Genomic Medical Services Alliance, there's 7 in the country. And as you can see, the regions are a little bit strange. They don't map to any other regions or NHS England regions or any other. But they're kind of based around the genetic laboratory hubs. And each of the GMSAs has got a lead trust and a lead laboratory. And it's to try collection of the trusts and NHS providers in that region to work strategically to give patients more equitable access to standardised care pathways, and to sort of mean that patients have more opportunities to be involved in clinical trials, because previously it's been patients that are being treated at the tertiary hospitals like UHL would be offered more opportunities to participate in clinical trials, which obviously isn't equitable. And so to make sure that the treatment is more equitable. And if we go to the next slide, I'll show you what the East Genomic Medical Services is in alliances in greater detail. So as you can see, it's Cambridgeshire, Suffolk, Norfolk, Hertfordshire, Bedfordshire, Northamptonshire, Leicestershire, Derbyshire, Notts and Lincolnshire. And there's 4 principal partners, so Nottingham University Hospitals, UHL, Cambridge and Norfolk and Norwich. And the lead laboratory is at Cambridge for our GMSA. And although a lot of the conditions I've spoken about have sort of focused on acute trust, there will be pathways that, span community trusts. And I would imagine that in the future, the sort of advances that we've had in cancer, selecting appropriate cancer medication will apply to other conditions as well. So on the next slide is our little team. So we've got myself and Vicky as nurse leads, and then we've got Melissa, who's based at Norfolk and Norwich as an associate nurse, and our project manager, Katie, based at Norfolk and Norwich. And then on the next slide, so obviously because the nursing workforce is so, and midwifery workforce is so massive, I think there's about, there's about 350,000 nurses and midwives, 100,000 nurses and midwives in post across England. So the GMSA is broken down to take the lead on one of the transformation programs. So the programs for last year, so nursing and midwifery as a whole, as I said, that's a huge, huge area. And there's lots of variability, and from what you've said as well in your presentations about what a clinical nurse specialist or an advanced practitioner actually does, there's huge variability from organisation to organisation, so it's looking at that. There's pathology, there's a DYPD gene, which was the one I mentioned about chemotherapy. Our GMSA was leading on sudden cardiac death, got monogenic diabetes, familial hypercholesterolemia, and a type of an inherited syndrome called Lynch syndrome, which increases people's risks of developing bowel cancer. So, I mean, all of certainly these, the conditions listed, it means that the genetic test, it'll influence the treatment that an individual has and sort of improve the quality and quantity of their life and reduce mortality and morbidity. So it is quite a quality and safety issue as well. So if we could move to the next slide, please. And so in 2021-22, Vicky and I were recruited quite late into that year. We didn't start in post till Q4, so we had a lot of catching up to do. So one of our first tasks was to do some benchmarking across the region to find out the level of nursing and midwifery integration into genomics. And so it's a national toolkit, and so it could be replicated across the country. And it's not, the toolkit wasn't designed to be a scientific piece of work because it wasn't possible within the time frame to do a rigorous piece of research and, you know, make sure we recruit 10 people who are ACPs, 10 people who are academics and so on. It was just a bit of a finger in the air to give a flavour of where nursing and midwifery knowledge and expertise is in the field of genomics. And unsurprisingly, it's scored quite lowly. I mean, there are areas of, you know, excellent practice, but they tend to be outliers. For, you know, a lot of nurses and midwives, it doesn't really come into their everyday practice. So what we were sort of wanting to do is like slowly develop, I suppose, quite a lot of networks of nurses and midwives to gradually cascade the sort of genomics information across nursing, so it grows within nursing, and it's not a sort of just a top-down approach from NHS England, you will do this, you will do that, and it's that nurses can identify opportunities in the sort of pathways of patients to improve their care. So from last year, we've been looking at Lynch syndrome in our, you know, Q4 from last year, and we're looking to build a network of clinical nurse specialists in colorectal cancer and gynecological cancers to improve patient care pathways there. And so for Lynch syndrome, so we've got two types of genetic testing that can happen. There's one on the tumour, and that's to help find out is the patient at risk of this inherited syndrome, and the other type of testing is to find out which type of treatment might be the best for this cancer. So we've got anecdotal evidence that sometimes the tumour testing is being done, but it's not always acted upon, which is a bit worrying. And I'm not saying it's a nurse's responsibility, you know, to do that because he or she won't have taken the biopsy from the patient, but they would, you know, this is one of the things with this is to help increase nurses' confidence at speaking up in the multidisciplinary meeting to plan a patient's care. And then also nurses being able to identify where genetic testing in the patient's wider family can reduce that person's risk of developing cancer or more serious cancer by earlier diagnosis. Going to go on to the next slide. And our projects to work on across the next 2 years, because I said, you know, the nursing workforce is so huge, it's probably not possible to tackle everything all at once. There's only 7 teams, so we've got 7 regions. So we've got 7 areas, so 4 cancers, lung cancer, carrying on the Lynch work from bowel cancer with wider colorectal cancer, breast cancer, and ovarian cancer. Then 2 rare diseases, so polycystic kidney disease, familial epilepsy, and then improving the fetal-maternal care pathways as well. And what we're looking to do is identify work with nurse specialists who are very much patient facing to identify, I suppose, key touch points in the patient pathways and look for areas where genomics can be involved and influence the patient's care. And then if you move on to the next slide. So our first sort of area of focus is lung cancer, and as I said, it's to help to support nurses to identify and define exemplar pathways that can be embedded appropriately across patient care pathways and improve equity of access and reduce unwanted variation. So we're sort of scoping, identifying the lung cancer CNSs across the region, scoping current pathways, and then hopefully having some workshops with lung CNSs from each region to help develop lung cancer pathways in line with national strategy. So then the next slide, please. And then it's how to get involved. So depending on what level of you are, it would be considering genomics in the development of your nursing strategy, maybe genomics workshops for staff on different aspects, thinking about where it's already in place, and then considering featuring it in team leader meetings. And we've got a nursing and midwifery genomics link network. And I think there's somebody, I can't remember the name of the person from your trust who joined us. And what we have that person to do is, if there's sort of information that needs to cascade, or we need to identify an individual group of CNSs, APs, ACPs to help us with a piece of work. Oh, it's Emma. It is Emma. Yes, I'm sorry, Emma. And to identify a piece of work, then Emma would be able to direct us to you, or Emma would be able to cascade information to you. And we've got a monogenic diabetes clinical network as well. And I just give a plug for monogenic network. So diabetes, very complicated, lots of different pathways, care pathways. There's one type of diabetes that is inherited, and the gene for that has recently been discovered, and people were being treated inappropriately with insulin and other medications. They find out they have genetic testing based on, their clinical history, family history, and in some cases people are no longer insulin dependent. Their sort of retinopathy has slowed down, slightly reversed. So that's a really good news story for that one. And then the next slide is and then there's quite a lot of training for nurses and midwives around. So there's health visitors. There's a Health Education England have got it's called Genetics 101. It's not Room 101. It's not that bad, honestly. And it's a sort of short sort of e-learning packages on different aspects of nursing and health visiting. And then there's some patient stories up on our website. So I think that's all my slides, I think. And has anybody got any questions? Or Vicky, did you want to add anything? Have I missed anything out?
No, I don't think you have. I think you've covered everything. I suppose, and I think you have sort of talked about what an opportunity it is for nurses. It's to be part of the transformation. And whilst we really recognise the pressures on nurses, and we're working with midwives as well, you know, we're having to try to be creative about how we can engage with them, because, you know, we know that everyone's, you know, really stretched, but we also want to ensure that they are part of the conversation, so that they can, you know, help inform where we go next. And so it's quite an exciting time for nurses, I think, to be part of that. And that's our responsibility, to make sure that you know, we are talking to people that are closest to the patients. But yeah, that's it from me. But thank you for inviting us. It's been really good to be part of your International Nurses Day celebrations.
Lovely, thank you. I think Emma's got a question.
Well, thank you, Annette, and thank you, Vicky. It is me. I'm the link, the organisational link, and I attended that the network meeting, and I think what struck me is how we start to have the conversations around genomics in nursing. I think the RCN also have got a nice a sort of easy read approach to what it is, and I think as well, thinking sort of connecting in the advanced role, it is that sort of taking history, isn't it, and family history. And I know Annette and Vicky, when we had the presentation, you talked about was it the presenter who died of
it was David Frost.
David Frost,
yeah.
And actually, with advancing roles, that sort of connection in terms of history. So there's lots of education resources. I've not started to look at some of the links yet, but yes, there's lots of links to the different, and they're bite size, aren't they? So
yeah.
What I wanted to do was start to spread the word, and they are very physical health related at the moment, but I'm sure that things will change, won't they, as it grows. So thank you for coming today.
Definitely. Oh, thanks, Emma.
Yeah, thanks for having us.
Okay,
I've just got a question, if that's all right. I just saw on one of your slides you've got some mental health trusts involved in that as well, and I'm really interested as to where genomics and fit with mental health, or whether or not there's anybody doing any genomic work in the area of mental health that you're aware of.
I'm not sure specifically, but I do know that pharmacogenetics is a really big field. And I know, obviously, pharmaceuticals aren't the only treatment for mental health conditions, but there does seem to be quite a heavy reliance on them. So I wonder if in the future there will be more targeted therapies, because I know, some people have different responses to some of the medications. So I wonder if, in future that will be more targeted and more individualized.
Yeah, lovely. Yeah. Thank you. Has anybody else got any questions? Can't see any hands up. Thank you. That was really, really interesting. I really enjoyed that. So thank you for your time.
Thank you. Bye-bye, everyone.
Bye.
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 Just like to go to the next speaker now, which is Shannon Graham, who works in our children and adolescent mental health services, and is going to talk to us about the journey towards advanced clinical practice in those services.
Hi, I just want to check that I can be heard. Sometimes my equipment's a bit temperamental.
You're a bit quiet.
Is this any better?
A little bit.
It's because I'm in a shared office with no free rooms.
Anita's just loading your presentation.
Thank you. Yeah, so I wanted to discuss, I was invited to discuss my journey to being a trainee advanced clinical practitioner within CAMS, and I thought it'd be quite helpful to try and explain the variety of a journey that I've been on from I decided to come into nursing. I come from a family of a lot of nurses, general nurses, paediatric nurses, and mental health. And quite early, probably around 15, 16, I knew that I wanted to follow one of their footsteps. And my heart kind of always drew me towards mental health nursing. I trained at Queen's University in Belfast. I'm originally from Northern Ireland. And at that point, you undertook a generic nurse training course. So everyone went in on an adult branch course, and then at the end of that, you decided whether you wanted to specialise, which was an additional 18-month top-up into either mental health or paediatrics or midwifery. I qualified, first of all, as an adult nurse, and initially I worked within a community hospital. It was a stroke rehab unit. I realised that it didn't really set my heart on fire, and it wasn't the area that I wanted to work in. So I then went into medical research, where I worked in a unit that provided first in human dosing for new pharmacological treatments. Again, wasn't kind of what I wanted, so I decided to kind of go with what I originally thought and do my top up into mental health. And while I was doing that, I worked as a healthcare assistant on our CAMHS unit in Northern Ireland. There's only one CAMHS unit for the whole country, so there's 12 inpatient beds for the entirety of Northern Ireland for anyone under the age of 18, and that includes from kind of 4 to 18. There's 12 inpatient beds. I worked between there and the medical research while I was doing my top up into mental health. Quite quickly following placements, I knew that I wanted to learn more and work with those individuals that were actually rejected within Northern Ireland, so those with personality disorders and quite often complex trauma. The mental health order, which is the legal framework in Northern Ireland, actually doesn't make any mention to someone having a personality disorder or drug misuse as being warranted for treatment under the mental health order. So quite often those individuals end up in the criminal justice system without any sort of care or support. So that quite quickly made me realise that I needed to come to England to be able to treat and to care for those individuals with those conditions. I did an elective placement in Broadmoor in West London, and I agreed to work there initially. Unfortunately, I was put onto their intensive care ward, ISIS, as a newly qualified nurse, which for any of those that work in mental health at the minute, if we can imagine the restrictions of a PICU and then multiply that by about 100 to imagine what a PICU in a high secure hospital looks like. There was no therapeutic involvement really at all. It was very much medical model, dispensing medication. The nurse's role wasn't very therapeutic at all. So I moved to a medium secure female service that was a specialist service for individuals with personality disorder. I absolutely adored my time there. I always wanted to do more to help those individuals. And I actually rotated between the female medium secure and the CAMHS medium secure service, where I was supported to go on and do my DBT training, to offer kind of more of a therapeutic role, more of therapeutic intervention to those with those conditions. I spent 9 years doing that, and then I decided that I would like a break. Whilst I was in the medium secure units, I had always wanted to kind of go further and do a step more. I think like some of the previous, I think Angela and Dan said earlier about that autonomy, I always kind of wanted that. I always felt there was a lot of restrictions, quite often waiting on, medical oversight. I saw that actually the individuals that I really enjoyed caring for didn't necessarily need that medical oversight. What they needed was a very experienced, clinically focused and therapeutically engaged person to work with them, understanding their journey, understanding their trauma, and working alongside them to get the best outcomes. Unfortunately, funding was not to be seen. And then I moved to Leicester to their CAMHS community team. Absolutely adored my time there. However, there was some difficulties, I think, with getting more registered nurses onto the inpatient ward, and because I had a lot of experience in inpatients, I agreed to support on the ward. And one thing led to another. I was initially rotated for 3 months, and over a year later, I'm still on the ward, and that's by choice of my own. I was supported by both my community colleagues and my colleagues on the inpatient ward to consider my own professional development, and that was to go down the ACP route. So with a lot of support, a lot of guidance, a lot of discussions, a lot of emails and a lot of research, we were able to kind of establish that it's something that the CAMS team were able to support, and that I could attend Coventry University to complete their ACP under their mental health branch. King's College London did it, and that was one of the other ones that I was considering, but because of my own kind of circumstances, I needed it to be closer to home, and LPT and FYPC and the CAMS team were really, really supportive of that. So I'm currently about to restart my second module. I've just finished the advanced health assessment element of it, and it was a rude awakening into things that I thought that I had forgotten for a long period of time, and things that I'd never even come across in the past. I'm really, really enjoying it. We've made quite a good network, both within the students that I'm with at uni, but also within the mental health team within LPT. Vicky's actually arranged supervision for us, for peer supervision, and it's been really, really helpful. Again, the role of the ACP within CAMS inpatient unit is something that hasn't been done before, and it's something that I think as a team we're still trying to confirm what it's going to look like on qualifying. But it's quite an exciting time, and it's really exciting to be part of that and to be within this role doing it. My last slide was going through the 4 pillars of practice, but they have thankfully already been discussed. So that's it from me. Thank you.
Lovely, thank you, Shannon. That was really, really interesting. Has anybody got any questions? Oh, I can see Angela, you've got your hand up.
Hi, thank you, Jackie. Hi, Shannon. I think this is really exciting that these roles are developing in other services and in different ways. I think I just wanted to say a couple of things. When you're debating about how the role's going to be when you're qualified, use the framework, because that is a really good, it sets it all out and how to sort of take the role forward. And also as a trainee, we've had lots of trainees go through our service, and there's not one person that doesn't go, oh my God, I can't do this. So and there's not one of them that hasn't come out the other end and been absolutely brilliant. So you stick with it. It sounds like you'll be absolutely fine.
Thank you, and I have written yours and Dan's name down as I may contact you for support, if that's okay.
Carmela?
Thanks, Jackie. Thank you, Shannon. That was such a good presentation, and I always love hearing the story behind where everyone gets to. And I think the more senior up that you get, people just look at your title and they don't realise the wealth of knowledge that you bring with them. I think it's really interesting how different your training was in Ireland. And I'm just thinking, do you think that was a positive? Do you think that set you up with some of the skills that maybe we don't have? And do you think that's helping you now on your course?
I think in my early days as a newly qualified nurse, it definitely did. I think we all know the comorbidities of physical illness in mental health, and quite often where something that came up quite common was cellulitis in someone's leg, but actually how do you differentiate between that and a blood clot? And that wasn't even being considered quite often by those that had purely entered through the RMN route. In terms of helping me with my course, some language is familiar, but because it's been so long from I've actually done it, I wouldn't say that it's made it any easier, but it certainly makes the initial understanding a little bit easier. And we had massive anatomy and physiology and pharmacology modules whenever I was at uni. So I've been able to kind of refresh a lot of that. Obviously, it's a complete step ahead, but knowing the language was certainly a bit of an advantage.
Claire?
Thanks, Jackie. It was just to say, Shannon, in DMH, we've got a peer group for trainee and qualified ACPs in mental health. And I hadn't been aware that you were training, otherwise I would have invited you. But I think Tracy Kirby was going to get in touch and invite you.
Yes, she has, and Vicky Noble. I've attended some of the supervision sessions already.
Yes,
Thank you, though.
More than welcome. There might be some DMH talk, but hopefully you'll find it useful.
It has been. It's been really helpful from a reflective point of view, actually. It's been really, really helpful.
Brilliant.
Any other questions? I can't see any hands up. No. Thank you, Shannon. That was great. Right, that brings us to the end of all the presentations today. So we have actually got an Ask the Panel question slot. So I'll just open it up to see if anybody wants to ask any of the other people that have presented today anything that they didn't ask at the end of the presentations. No, I can't see any hands. Okay, well, I'd just like to thank everyone for attending. I think it's been a really interesting session, and I'd like to thank everyone that's presented. It's great to hear about all these developments that are happening all over the trust. I think it's really exciting. And I'm a bit like Claire, sort of coming to the latter end of stages of my career, and it would have been really nice to have had these opportunities sort of much earlier on in our career, but it's great for nurses that are coming up. So I would just like to thank everyone for coming, and hopefully see you on some of the other sessions over the next 3 days.
Thanks, Jackie. Great session.
Take care, everyone.
Thank you.
Thank you. Bye.
Anita?